Hi, everyone. Thanks for tuning in. My name is Skrzynski. I'm one of the infectious disease doctors as well at the Holloway Community Program. You heard from some of my wonderful colleagues earlier in the panel discussion. I'm going to be talking about, what we call preparing primary care for PrEP, but this really goes for anybody who wants to prescribe PrEP. So let's dive in. I think that the most important, cohort of, prescribers who are going to be seeing people on the front lines are the primary care doctors. And that if we have a hope of meeting our goals for PrEP, which is extraordinarily effective and safe, as I hope I can convince everyone, that we can, significantly put a dent in the HIV incidence. This is from 2015, but it's clear that the awareness of PrEP and how it can be prescribed is very, very low. Only 1 in 3 primary care doctors in 2015, primary care doctors and nurses, I should say, hadn't heard about PrEP. So hopefully the word has gotten out since then. But I still think there's a ways to go. So the history of PrEP is goes back to 2012 when the first agent, and I'll try not to use trade names, but I think it's important to kind of know what the brand names are so that we can kind of have a common language. So FTDF or Truvada was approved in 2012 as the first agent. And then in 2018, that indication was extended to younger age groups. The USPSTF gave PrEP a grade A rating in 2019. And later that year, FTAF or Descovy was approved for use in MSM and transgender women. And then in 2021, DHHS made a very important statement which allowed for PrEP medications testing and visits to the clinic to be insured by most commercial insurers and some Medicaid programs. So coverage of PrEP and its related lab tests and immunizations and things like that has been very, very important to promote PrEP uptake. And then the most recent addition to our armamentarium in 2021, the end of the year, came long-acting injectable cabotegravir. Apretude is the brand name for that. I wanted to talk about PrEP in the context of the status neutral approach, which is a concept that really seeks to integrate both prevention and treatment, where people, irrespective of their risk factors, are offered HIV screening. Whether or not they're positive or negative, they can still benefit from prevention and or treatment in whatever category they fall into. And the status neutral approach has been used successfully in select locations around the country. Essentially, this is from the New York Department of Public Health. Essentially, we're just going down 2 different pathways where people with, negative testing and positive testing are still engaged in continued, clinical activities, whether that's prevention, providing barrier protection, oral PrEP, or treatment, the treatment side of things, if someone someone is diagnosed with HIV. So it's important to take on this holistic view of PrEP. So, why should we prescribe PrEP? Well, when we give it and it's taken correctly, it can reduce the risk of HIV acquisition by upwards of 99%. Less evidence for people who inject drugs, but this protection does go over 70% in this cohort. When we talk about injectable PrEP, which is studied in both MSM, transgender women, and populations and heterosexual women populations, there is additional risk reduction on top of oral PrEP due to the kind of mitigation of adherence issues that you would see in taking oral PrEP. So the injectable is not necessarily better in and of itself pharmacologically, they probably provide similar protections, but obviously we're taking adherence, taking that daily pill out of the question. And when compared to condom use, you can see that condoms offer about an 80% risk reduction in heterosexual couples, 70% in MSM. So PrEP is superior to barrier protection alone. Certainly, although barrier protection certainly remains a very, very important strategy. What is the risk of HIV acquisition? So this we'll get into a little bit later in terms of screening for people's sexual history and having, at least a brief discussion about it. But the highest risk types of exposures, receptive anal intercourse being the highest risk, insertive anal intercourse next, receptive vaginal intercourse, insertive vaginal intercourse. You can see later on oral sex, very, 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 very low risk. HIV being inactivated by enzymes in saliva. Compare that to like a needle stick injury, 1 in 333. So these are the risks that we're dealing with up front before we even start counseling about condom use or PrEP use. Important to know these and to know what types of sexual activities people are engaging in so that we can, offer appropriate prevention options as well as STI screening options. So in the United States, an estimated 1.2 million people have an indication for PrEP. You can see that the number of eligible people prescribed PrEP increased from 3 to 25% over a 5-year period. That's not bad. PrEP is thought to have reduced HIV incidence by 8% in the period between that 2015 and 2019. Now, the influence of the pandemic on PrEP uptake and maintenance probably has decreased its effectiveness somewhat, but hopefully we can kind of rebound from that now that people are coming back into care, are back in care. It's also the goal of the US government, and they're ending the HIV epidemic, that 50% of those eligible for PrEP be prescribed by 2030. I think we might be able to get there beforehand. But I think this comes down to the fact that who is prescribing PrEP is very important, and leaving it to, say, specialty clinics is just not going to get us the numbers that we need. It really has to come in from the ground up, from primary care, from those relationships. We'll see that PrEP can be very, very easily prescribed at any level of care, as long as there's good follow-up. The most important kind of risk group nested into kind of these other populations are those with virally unsuppressed partners with HIV, the highest risk in the green, the yellow, persons with identified PrEP indications. We'll go through all that. But when seeing a patient, for complaints of STIs or not, just for a blood pressure check, there are always opportunities, I think, to discuss PrEP and to identify who's at highest risk here. So, we want to talk to patients, and some of these topics can be at first uncomfortable. I think everyone can develop a style and a comfort level with talking about sex, talking about drug use. And again, that sexual history is not just important to identify risk factors for syphilis, gonorrhea, chlamydia, but the type of sex people are having dictates their risk for HIV acquisition. And I think that, in the context of PrEP, that's very important because it may incline, a provider to perhaps suggest it and have a more extensive counseling session. Obviously patients are not always gung-ho about talking about their sexual history or substance use, and that can be a hindrance. But even a brief targeted screening that avoids kind of an in-depth conversation can still be very effective, especially during a visit in which someone's addressing numerous other issues. Time is always a constraint. But again, what kind of sex, who they're having sex with, gender identity, and substance use, especially drugs that are known to increase risk of sexual behaviors like methamphetamine. So, all of that, really comes into play in the overall health of a patient. Indications for PrEP, so we can, talk to really everybody, anybody who could potentially be sexually active, adolescents up to adults, depending on who you see. And the indications are the same for both oral and injectable PrEP. If they have an HIV positive partner engaging in anal or vaginal sex, especially if that partner has an unknown or detectable viral load. So knowing the person's partner's HIV control status, not just whether they're positive or negative, but are they on antiretroviral therapy and are they effectively virologically suppressed? Very important. If someone's had a bacterial STI in the past 6 months, gonorrhea, chlamydia, syphilis, I think that we can, safely add Mpox infection to this list as well. Again, talking about sexual behavior, are they using condoms, barrier protection? We know that's not 100% effective, but it's at preventing HIV infection, but it is 70 to 80% effective. And then, if they are using drugs, are they sharing their equipment or works? Do they have an HIV positive injecting partner? Screening for things like hepatitis C here as well. It all kind of comes in a package. One of the questions that oftentimes comes up when I'm working with residents, and I know the residents here at ChristianaCare, in some of the clinical settings are learning to prescribe PrEP, which I think is wonderful, is, if a patient, comes in and wants PrEP, but they don't really give a great reason, what do we do? And the CDC actually answers this question. And, if someone does request PrEP because of concern about acquiring HIV, but they're not really telling you openly about, specific risk factors, you still, again, this is at your discretion, your judgment, but you still can go ahead and prescribe it. And the reason is because a lot of these conversations are heavily stigmatized, drug use, sex, very heavily stigmatized. And, people just may not want to offer that information. But if they do believe that they need PrEP and it's reasonable, the CDC says, yes, it's very reasonable to prescribe it, even if no specific risk factors are elicited. So, what else can we do when we're talking to people? Again, the partners of our patients who have unknown HIV status, they can get tested. The CDC actually offers a testing website where you can locate reliable testing sites. Again, if they have an HIV positive partner, understanding that partner's ART regimen, their adherence, their viral load, make sure the risk is low. Offering comprehensive STI screening and treatment and connecting to drug-related behavioral support systems. So all these things are, part of that PrEP milieu. A lot of people do that anyway for their patients. And again, it doesn't have to be done all at one visit either. Once you establish trust with somebody, I think that they are, much more likely to have these open conversations later on. So that can definitely be a targeted strategy. So who can get PrEP, after we've done this screening process? Well, number one, we want them to have a negative HIV antigen antibody test within 1 week of initiation of PrEP. As long as they haven't been on PrEP, the antigen antibody test, the 4th generation, is adequate. No signs or symptoms consistent with acute HIV infection. We'll go over those. Obviously, we want to make sure that they're not in that period of acute HIV infection, acute retroviral syndrome, or in the window period between initial infection and detection using our serology or our viral loads. We want to be cognizant of their renal function. We'll talk about the individual PrEP agents, but for FTAF, we're looking at a clearance greater than 30. For FTDF, a clearance greater than 60. Other important thing to be cognizant of is the fact that they're not going to have any drug interactions or contraindicated drugs. With oral PrEP, that very rarely comes into play. And there's a wonderful HIV drug interaction checker sponsored by the University of Liverpool, which you can Google, that has a really quick reference of the HIV antiretroviral drugs referenced with a huge database of other prescription medications. The signs and symptoms of acute HIV infection, and these are things that we want to be aware of, both at the initial visit and every time a patient comes in. They're not specific. Flu-like illness, very common. And, it's often taught, and I think it's so true, that if someone's coming in for a flu-like illness and they haven't had HIV screening, we want to think about HIV. Fever, fatigue, myalgia, skin rash, headache, pharyngitis, cervical adenopathy. Again, all these things are so nonspecific. But one of the very interesting things is if you have a young person with an exudative pharyngitis, we think about mono, you think about strep, but HIV is right up there with cervical lymph nodes and an exudative pharyngitis, and maybe they have constitutional symptoms. A rash can be quite common. Again, less than 50% of people, but it is noted. So all of these things are great opportunities, whether they're in an urgent care or an ER or primary care clinic, to consider HIV testing, especially if your spidey sense is heightened as to their risk factors. But really anybody without an HIV test, very appropriate to screen. So what do we prescribe? Well, we have at this point 3 major options here. 2 of them are oral PrEP. We'll talk in depth. And the third is an injectable, the injectable cabotegravir, which has come of age in the past year. Not something that every clinic or office will necessarily be able to offer unless you're super ambitious and want to do this. It's a specialized injection. But again, lots of referral options for all of these if someone does not feel comfortable prescribing it, but still wants to have the conversation. And I think that's very important. The issues with PrEP, I think people think about HIV and HIV treatment, and some people can become very intimidated if you haven't used these agents, especially if you're used to kind of historical antiretroviral drugs with a lot of toxicity and monitoring needs. None of these agents have those characteristics. And as a matter of fact, I think if you read on drugs like statins or lisinopril or anticoagulants, the PrEP drugs are so much safer and more manageable. So just by virtue of them being antiretroviral drugs does not mean that they're difficult to prescribe. On the contrary, very, very, very safe and effective, again, as with any prescription drug with monitoring. So if we look at the PrEP pharmacokinetics, we talked about the efficacy in the trial and the fact that if people are adherent for 7 doses per week of PrEP, their protection ranges up to 99%. It's interesting to note that you can see if their adherence drops down to maybe 4 doses a week, that efficacy still stays up there around 96%. I don't suggest this to patients. You do want them to take it every day, but just taking PrEP 4 times a week, taking PrEP 2 times a week still reduces your risk by 76%. Again, want them to take it every day, want them to get that near 100% efficacy, but it's still effective and still will contribute to our public health goal of reducing the incidence of of HIV infection, reducing new infections, and hence trying to put a stop to the epidemic entirely. With PrEP, we want to be aware of its uptake in various tissue compartments of the body, and there is a difference in when we look at males versus females, as biological sex was assigned at birth. So for lower vaginal tract tissues, you're going to require much higher doses, daily number of doses per week to achieve an adequate tissue level. So in women, we're looking at over 85% adherence. If you're looking at colorectal tissue, people who engage in anal intercourse, that goes down to 2 doses per week to actually gain effective tissue level, 28% adherence. So we do have time periods in which PrEP can become effective in these tissue compartments. For rectal tissue, 7 days, cervicovaginal tissue, 20 days. So this becomes part of that counseling where we do advise people to wait 7 days to achieve maximal protection. For anal intercourse, for vaginal, approximately 3 weeks. No good data for penile tissue as far as efficacy. One note is that if you use TDF, FTC, or Truvada, you can actually take a double dose on the first day, and within 24 hours expected to gain full efficacy for rectal tissue. This is not an option for heterosexual women, but it is an option for MSM engaging in receptive anal intercourse. So you can see that there's some nuances here, and this, I think, can be just part of that routine counseling. So let's kind of dive into some of the individual PrEP agents. FTDF, again, just to minimally use brand names, Truvada, but I think it's important that you know, because that's how patients are going to refer to them. This is a HIV nucleotide reverse transcriptase inhibitor combination. Has been out for a long time in terms of HIV treatment. We have a lot of track record with it, and it's indicated, it has data available for people at risk for HIV acquisition through sex or injection drug use. And it's a once daily tablet, and it's very, very, very well tolerated. People may have a little bit of a startup syndrome, headache, malaise, abdominal pain. There may be some weight loss associated with this agent, not extensive weight loss, but people may drop 5-10 pounds. The does seem to suppress appetite, and there may be some metabolic effects there. With this agent, we want to make sure that the creatinine clearance is over 60. And there have been small decreases in renal function observed in the PrEP trials. And these were mostly reversed when discontinued. We'll talk about maybe like a 1% change in renal function. In HIV treatment, it's a little bit of a different situation where we do see some rare cases of acute renal failure and Fanconi syndrome. The proximal tubule can be affected by tenofovir disoproxil fumarate, but again, not typically seen in PrEP. And the difference there, I think, is just cumulative exposure. If you're in HIV treatment, people were on these for many, many years. For PrEP, while people can choose to be on it for years, it's really, indicated for those high risk periods. So people may come off and on of it. Bone density is also something to take a look at. The IPREX PrEP trial demonstrated about a 1% decrease in bone density in the first few months after using PrEP with TDF FTC, and that either stabilized or actually returned to normal. This is different than HIV treatment with TDF FTC, where it was about a 3 to 4% decline in people. And the important thing is that 1% decrease in bone mineral density that may or may not remain persistent actually resulted in no fragility fractures over 1 to 2 years of observation. So clinically, it appears not to be super relevant, but it is something to know about the medication. The other factor that comes into play is when we're doing and assessing for PrEP, we want to make sure that someone does not have active hepatitis B infection or chronic hepatitis B infection, because both of these agents are active against hepatitis B, FTC weakly so, TDF being a mainstay of hepatitis B treatment as a monotherapy. So if you were to put PrEP on board in someone with chronic hepatitis B and then take it away abruptly, it can potentially theoretically cause a flare in the hepatitis B viral load and consequent viral hepatitis clinically. So again, you want to be careful of that. But those are basically it. Perhaps a small decrease in renal function that's potentially reversible, 1% bone density loss, and just vigilance for hepatitis B. Again, the drug interactions, the HIVdruginteractions.org, wonderful website from the University of Liverpool that is so easy to use. Takes a couple seconds just to run these things through. in a clinical situation. So this is our first PrEP agent approved in 2012. Later on came tenofovir alafenamide combined with FTC or TAF FTC or Descovy. And this is similar to Truvada or TDF FTC. It's a nucleoside nucleotide reverse transcriptase inhibitor combination. We use it in HIV treatment. Now, this has only been studied though at people at risk through sex, specifically in men, including MSM and transgender women only. People who have been assigned female biological sex at birth, heterosexual women, are not a study population with drug, unfortunately. So we're using it only, again, in biological males at birth and transgender women. It is a single daily tablet. Most common side effect, which is extremely rare, is diarrhea, usually as a startup syndrome, which is then kind of alleviated within a week or two as people adjust. You'll notice that it's can be used at a lower cutoff for creatinine clearance, and no decrease in function observed in the single PrEP trials evaluating this. So tenofovir alafenamide versus tenofovir disoproxil fumarate, the quick 2-second explanation is that the TAF compound, the newer compound, has a lower extracellular concentration, higher intracellular concentration, so lower systemic toxicities. Does not appear to dramatically affect the proximal tubule in the kidney, does not appear to be associated at all with Fanconi syndrome or a significant loss of renal function. So this is really, really nice. It's nice for HIV treatment, nice for PrEP. Would be nice if this was studied in other populations as well. Let me skip to bone density just to compare to TDF FTC. No decrease in bone density here. As a matter of fact, a slight increase in the bone mineral density of the hip and spine through 96 weeks of the Discover trial, which evaluated this versus TDF. No difference in the frequency of fractures versus TDF FTC. So again, no real appreciable renal issues, no real appreciable bone density issues. One ongoing area of research here is looking into the association of TAF FTC, or TAF in particular, with a slight increase in lipids, and could include triglycerides as well as higher rates of weight gain. Now, is this a metabolic consequence of TAF? Possibly. The other flip side of that is that TDF is known to suppress weight and also has a lipid lowering effect, which is interesting. Not by much, not like a statin, of course. But when you compare them head to head, it might appear that TAF FTC is a bit more exaggerated in terms of its lipid effects and weight effects. In any case, it is important just to mention this. We're not talking about significant weight gain, and we'll go over that in a minute. Hepatitis B is also a concern here. TAF also has excellent activity against hepatitis B. FTC or emtricitabine less so, more weakly active. So we have to be concerned again about hepatitis flares. In other words, need to know the hepatitis B status here as well. It's a very nice slide, which I love to print out for patients, although it's a Twitter slide, so it's kind of hard to access through the system now and print. But I do show the patients. It's a very nice comparison of TDF FTC versus TAF FTC, summarizing what we talked about in terms of the GFR, a 2-point reduction versus a 2-point improvement, 1% reduction in hip bone mineral density versus pretty much neutral. You can see that with TDF FTC, about a 6.5-point reduction in LDL cholesterol versus a 1-point increase. And then body weight on the TDF FTC neutral, about a 1.1 kilogram increase in body weight on TAF FTC. Now that should be noted that that's more prominent early on in treatment and also pretty much mirrors the average weight gain for a given American in a given year. So the average American gains around 1 kilo per year. And so, is that is it the TAF? Is it the comparison head to head? It's a complicated issue, and weight gain in general is a hot topic in the antiretroviral research field right now. But this is a nice overview. You can Google this. This is from Julia Marcus at University of California, San Francisco. And a really nice handout for patients, or at least something they can just look at on the computer screen. So, there are some factors that come into play when we discontinue oral PrEP, and the protection there wanes over the course of about 7 to 10 days. Kind of makes sense. And you can see that this is a graph from the CDC on the y-axis. We're looking at HIV incidence, and then on the x-axis, different categories of people. Obviously, if you're linked but not prescribed PrEP, your incidence is 0.87. Prescribed, did not take, about the same, 1. Goes up if you stopped and did not restart PrEP, 1.28. If you stopped and restarted, it goes way down, 0.28. And then obviously, if you're persistent on PrEP, it's 0. So that's kind of an amazing thing, right? PrEP is so effective. And as you just saw from the preceding slides, so non-toxic and very easy to prescribe. Let's talk now about injectable PrEP, just to get everyone on the same page, make people aware that it exists. And we do injectable PrEP here at Holloway. Anecdotally, very interesting. I think a lot of my colleagues would agree with this. There's been not so much interest in this versus oral PrEP. Versus on the HIV treatment side, where we have injectable HIV therapy, including this cabotegravir long-acting injectable, where there's quite a bit more interest on the treatment side. So injectable PrEP exists. Like I said, it doesn't seem to be as popular. People seem to prefer the oral therapy, perhaps because of the flexibility of it. Cabotegravir is in a different class. It's a second generation, so to speak, integrase strand transfer inhibitor. And this has been studied in people at risk through sex. It's a 600 milligram injection of cabotegravir into the gluteal muscle every 2 months. It's a special placement of the needle. Has to be given really in the clinic setting by people who are trained to inject it. There's an optional oral lead-in of the same medication for 30 days that can be taken daily. But one of the wonderful things about cabotegravir injectable is that, excuse me, we don't really need to know the creatinine clearance to start it. We don't need to know the hepatitis B serology, although we probably do, because then we can offer vaccination and make sure that people are linked to treatment if they have chronic disease. But the medication doesn't interfere. It does not have effects on lipids, and it does not have appreciable effects on the liver. Although that's one of the in the package insert, you have to be careful about transaminase elevations, but clinically that rarely, if ever, happens with these drugs. BMI can be tricky. We have to inject this into the gluteal muscle, and it has to get to a certain spot. And if people have a high BMI, it's very difficult to achieve this. So that is one consideration in people, especially with BMIs over 40, how to administer this, and whether or not the pharmacodynamics and are even well established at this point. They really aren't. The most common downside is injection site reactions. They're generally mild or moderate, last a few days. Most patients say it's like getting an intramuscular injection, maybe like a tetanus shot, and then it does fade away. Significant local adverse reactions are extraordinarily rare. I don't think we've had one here. Discontinuing injectable PrEP. So whether or not you're prescribing injectable PrEP, we want to be conscious of its effects on the risk of HIV acquisition. And injectable PrEP, cabotegravir, is a very, very long half-life. Some people mention years in the literature. Certainly, most of that is not at therapeutic concentration. So the tail, as cabotegravir tails off, that tail will go under the therapeutic range at some point. And again, if someone is exposed to HIV, it can place that person at risk for developing resistance to cabotegravir and related drugs, such as the other integrase inhibitors. So we have to be very, very careful when people are discontinuing. oral PrEP, but more specifically in this context, the injectable PrEP, make sure that they have good counseling about that. They need to be extra careful in this setting. Perhaps a kind of a chaser of oral PrEP is indicated for several weeks. If there's a persistent risk factor, non-occupational post-exposure prophylaxis can also be used in this setting if there is an indicated HIV exposure. And then the guidelines also recommend quarterly testing for HIV infection upon discontinuation of injectable PrEP for 12 months after. So, PrEP is not really something that we love to just kind of have people stop and then just disappear and never come back. That does happen. But in an ideal world, both with oral and injectable PrEP, we're kind of involving them. Again, if you go back to the model at the beginning that we were talking about, both arms of that HIV testing algorithm, we really want to keep people in care and continue to discuss those risk factors so that, we can, we're not turning success stories into failures, because I think that people do take that education into mind. And when we look graphically, a representation of the decline in injectable PrEP cabotegravir levels, that where we see the most risk is at a certain level of subtherapeutic drug exposure and certain amount of HIV viral load. Once that drug exposure kind of becomes a minimal on that asymptote, you're really not out of that range for risk of resistance. But you have to be careful where there's subtherapeutic drug level, but high enough that it exposes the virus to selective pressure, and then mutations result as a result of that exposure. So how do we monitor on PrEP? It's very simple. And the CDC has really nicely, I think, simplified these guidelines and made it easier. The mainstay of that is going to be your HIV antigen antibody testing. I mean, why are we doing HIV PrEP, right? We're preventing HIV infection. If someone comes in at baseline, they haven't been on PrEP for 3 months, then you can just run that 4th generation antigen antibody test. Once they're on PrEP, the CDC is now recommending that we also employ a viral load assay. A couple comments about that very quickly. One is that if you are on PrEP and you become infected with HIV, the time to serologic diagnosis or virologic diagnosis, if you're using a viral load, gets pushed way into the future in certain cases. So PrEP, drug levels can mask HIV infection, can delay that seroconversion, and can also artificially lower that viral load. Sometimes, in some of these studies, you look and it's half a year, especially in the injectable PrEP studies with the potency of the injectable integrase inhibitor. But just to make a long story short, adding that HIV RNA assay is thought to increase sensitivity for detecting HIV. Next up, though, that assay has costs to it. It's expensive. And if it's not covered by the patient's insurance, that can be a deterrent for PrEP. So I do try to have that conversation with people. And if they find that the viral load is exorbitant, you still can omit it from your algorithm. Don't have to use it. But the HIV antigen antibody testing, again, we're always going to include that. If you can use the viral load, it is recommended. This specifically came out of the injectable PrEP literature, the impetus to include this, but that concern for delayed diagnosis has been there for some time with oral PrEP. And labs can be done every 3 months. We want to fill PrEP for 3 months and do labs every 3 months, have that face-to-face interaction, or via telehealth. PrEP has a very, very, very unique position in that, there's no specific physical exam indicated to prescribe PrEP. Certainly if someone complains of an STI and they want to be examined, but to prescribe PrEP or to assess for it with no other concerns, telehealth, I think, is a very, very, very nice opportunity here. We want to do baseline and then 1 in every 2 month testing for injectable PrEP. And the same goes for other STI screening, renal function, access to clean needles and drug treatment services if applicable. So those every 3 months or every 4 month kind of cycles of counseling and testing and prescribing, help to keep people in care and help people to, keep that risk in mind. I think that's so important. Ambiguous HIV test results, they do happen. There are some options. I'm not going to go over them here. It's kind of out of the scope, but I did include this slide for reference. There was a national clinician consultation for PrEP. Ambiguous test results, they can run through the scenario with you. Same day PrEP. This is a concept that's been proposed using the point of care HIV testing. So that's something that can be done. Drawing a lab creatinine and an HIV test at the same time, prescribing it, and then altering course based on results. This may or may not be your cup of tea, depending on capacity and ability to kind of feel comfortable prescribing PrEP. The 2-1-1 PrEP regimen, this is not FDA approved, but it is out there. So if people hear about this, it's event-driven or intermittent or on-demand PrEP, which is a non-daily dosing regimen of PrEP. You take PrEP, 2 doses of PrEP within 24 hours of sexual intercourse, and then 1 dose 24 hours later, 1 dose 24 hours after that. And the efficacy in some of these international trials in Canada and France, over 86%. So it depends. Some people do prescribe this. It's not FDA approved. It is recommended by one of the major HIV guidelines, the International Antiviral Society. So again, it's a personal preference, a logistical preference, and but it is available for people who this may benefit. The other key thing is conception and pregnancy, where we're seeing now that PrEP is recommended for women attempting contraception if they're pregnant or breastfeeding. And this is using TDF-FTC, and if in the setting of a partner or a spouse or someone who has active HIV infection. Now, especially if they have an unknown viral load or detectable viral load or they're non-adherent. But even if not, even if the partner is suppressed, PrEP is still an appropriate offering here. We talk about U equals U in the HIV world. Undetectable equals untransmittable. A viral load less than 200 copies for more than 6 months. Well, even if their partner has a viral load less than 200, again, the risk of transmission is virtually none. But PrEP can still be offered and would be still appropriate, really, in anyone based on patient preference, but especially in the setting of attempted contraception or pregnancy or breastfeeding. Pregnancy registry provides, again, no evidence of adverse effects with TDF-FTC. TAF is also found to be safe, but not well studied. And again, is not a recommended regimen in women. Likely limited exposure to the PrEP agents through breast milk as well. So just some additional points here to keep in mind when or if choosing to prescribe PrEP. So overall, I think not only is it an amazing chance to increase PrEP uptake, i.e. providing PrEP at the primary care level, because again, this is where most of those clinical interactions are taking place. But it's an opportunity also to bring people in for their preventative screenings, their overall sexual health, vaccinations. In the PrEP world, we really want to concentrate on potential sexually transmitted infections, as well as infectious diseases linked to certain epidemiologic risk groups like hepatitis A, B, HPV, and meningococcus. Screening for hepatitis C, again, it can come along with all of this: depression, substance use, intimate partner violence, and also an opportunity, again, just to engage people, their cancer screening. So, all of this stuff is imminently doable at the primary care level. I would advocate that we really should be teaching PrEP in residency programs, family and internal medicine residency programs, anybody, OBGYN programs, anybody who's going to be interfacing with people on the primary care level. PrEP is such a powerful and safe tool that really anyone can prescribe and use. You do not have to be an infectious disease doctor or an HIV expert or in a Ryan White clinic or infectious disease setting. You know, you don't have to work for the health department. Really, anyone interested in PrEP can do this. There's a lot of guidance. I know that anyone at the Holloway program, you know, if anyone wants to reach out to us for assistance or consultation, we're always available, as well as our services through the AETC, the MidAtlantic AETC, always consultation and PrEP services available. For people who don't want to prescribe it, you know, even asking the questions and then referring are totally appropriate. I think anything that increases PrEP uptake and the numbers of people on PrEP will continue to drive down the incidence of new infections of HIV and you know, bring us closer to our ultimate goals. Those are my references, and thank you very much.